All right. Well, I'm ready for you, Sasha.
Okay. Hi, everybody. Welcome to Congenital Heart Academy. We are happy to have all of you with us today. And we are just giving one more minute and people can come into the meeting, and then we are going to start with a few announcements. Okay, so I'd like to start the meeting today thanking Sasha for the great work that he's been doing on the mission trips, and he just got an award in the US for the great job he's doing doing this cardiac mission trips. God bless you, Sasha, and God give you health and strength to continue to do this to the kids all over the world. And please follow us on social media and subscribe to our YouTube channel. This meeting is going to be there, so if you want to check it again or share with your colleagues, please do so on our YouTube channel. And save the date for the World Congress of Pediatric Cardiology and Cardiac Surgery is going to be end of August, beginning of September 2023. So get your arrangements for traveling to the US next year. It's going to be awesome, I'm sure about that. I want to invite you for Dr. Anderson's series. It's continued to be amazing. We have so many things going on this series that is really worth watching them. All the other ones are already on the YouTube channel. So if you miss any of them, please take a look. We have great things going on. Diane Spicer and Adrian, they show the morphological species, the hearts themselves, and then Justine shows us 3D CT scans. So it's very nice. It's been very seen on all these images, especially on the 3D reconstructions from Justine, has been amazing. The relationship between what Dr. Anderson teaches and what Diane and Adrian shows us, and then correlating to the 3D CT scan. This is very nice. You're going to have Dr. Mary Cohen on the ECO series as well. So please join us in the end of April. And we don't have the flyer yet, but end of April, we have the journal club. We are going to talk about neonatology. It's going to be a very special journal club. So take a look on our YouTube, on our social media. So you're going to have to get to know when this is going to be, but this last Tuesday of every month. And on the last Thursday, we are going to have another meeting of the fetal series. And now with you, our dear Dr. Norman Silverman, talking about the ecomorphological comparisons on the hypoplastic right heart. Thank you, Norman, for being with us today. And please, guys, if you have questions, type on the Q&A chat box, and in the end of the meeting, we are going to be able to answer your questions and discuss things with Dr. Silverman. Thank you.
Well, good morning. I'm just trying to get my meeting up. Here we go. Can you see my screen, Grace?
Yes, perfect.
Okay. Well, good morning, everybody, and thank you for attending the session. I see that there's a lot of interest in this issue. So we're going to be talking about this form of functionally single ventricle, the pulmonary atresia with intact septum, which is not always a single ventricle repair. It can be a biventricular repair, but basically it's all kept together in this functionally single ventricle, which we've been talking about up to this time for the whole year. And if you're interested in looking at it, it will be available on the YouTube channel. But with commentary and additions, you can find this at www.md1world.com, and you can purchase the chapter for a mere $8 US. So let me just say that the definition is a spectrum of abnormalities. The cavity can be tripartite, which means 3 parts, bipartite with 2 parts, or unipartite with 1 part. And hearts can, as I've said, be functionally biventricular or functionally univentricular. So we're going to talk about ecomorphological correlations, and I've placed these 7 hearts together to show you the variability in the morphology from the point of view of the tricuspid valve and the size of the ventricle. So we go from low to high over here, and all of these hearts have pulmonary atresia, whether the atresia is shown or not. And I think that this is an abnormality which develops at some part of in utero or fetal life, certainly early on in the later embryonic and early fetal periods. And here is a heart with a tiny right ventricle. You can actually see the tendinous cords in this structure here, in this 4-chamber cut from a fetal cardiac pathology from my colleague Diane Spicer, who's provided me with some of these images. So this is the smallest variety. It's almost hard to see this on an ultrasound examination. Then here, the tricuspid valve has walled off the entire ventricle. The ventricle is small. You can see that perhaps there was at one time a little outlet to the pulmonary trunk. Here's the pulmonary trunk. This is aorta. And here's the cavity of the ventricle with the tricuspid valve totally obscuring the connection to the ventricle. And then there is the previous pathway to the atretic pulmonary valve. Here is a patient who's had a central shunt, aorta pulmonary shunt. We'll show you all of these pictures later on with echocardiographic comparisons. Here is the small right ventricle. It's been opened up. Here's the delimiting left anterior interventricular artery and the right coronary artery coming over here. So this is the right ventricle. Hypertrophied cavity, no infundibulum seen at all, and with a small but patent tricuspid valve. The next specimen is interesting. As you can see, the cavities get progressively bigger as we're looking at these. And here you can see that the ventricle is extremely hypertrophied. You can notice prominent arteries. Perhaps there were coronary fistulae present in this patient. And at one stage, the infundibulum was patent to a nice looking pulmonary valve here. But over the course of time, the hypertrophy has obstructed the right ventricular outflow tract. So here is, and there was a tricuspid valve because here's a tendinous cord leading to a small tricuspid valve. Now the next one shows a slightly bigger heart. The tricuspid valve is dissected to show patency here with a prominent anterior papillary muscle and an infundibulum which is patent but ends in a fibrous sheet obstructing the entrance into the pulmonary artery. So this is a very small right ventricle. And the last two I put separately because I ran out of space, but also I divided these because these, here is a tripartite ventricle. From here onwards, these are tripartite. These are bipartite, and this is a unipartite ventricle. So here we're looking at the connection as it extends. And here you can see a tricuspid valve. You can see a cavity with inlet and papillary muscles. You can see an infundibulum, and this goes down to an atretic pulmonary valve here. And then the last example shows a really reasonable sized right ventricle with prominent papillary muscles, a wide open infundibulum, and yet an atretic valve, which probably became atretic over the course. And many of these larger ventricles are ventricles that have a lot of tricuspid valve insufficiency because the valve, as you can see here, gets beat up from the pressure that it has to take in its development. and there's lots of tricuspid insufficiency. And ventricles that have this bipartite connection also develop coronary fistula, and this may be an example of one. I can't see any coronary fistula on this very heart over here, but we will show you them. So the larger the ventricle, the less the chance of coronary fistulae. The smaller, the greater, but this is not an absolute rule. So you can have big hearts that have coronary fistulae and that have ventricular dependent circulation, which we will discuss in a moment. So now, having looked at the inlet, let's turn our attention to the outlet of this ventricle. And here you can see a very primitive pulmonary valve with the three sinuses of Valsalva and a round, rolled, completely obstructed ventricle with a small area in the middle of it that looks like it was trying to form an orifice. And this is very important because the interventionalists will aim at placing their wire in this area and dilating the annulus here. Now, we're going to look at a series of progressions in pulmonary atresia. So here you have the most primitive variety. Then here, as you come up a little higher, you can see the pulmonary valve with more development of the sinus of Valsalva, but still with a domed orifice not completely formed. Here, the sinuses of Valsalva and the commissures of the valve have formed, but they haven't separated one from the other. And lastly, the most ideal situation for the interventionalist, where you see the three sinuses of Valsalva, you see the development of the cusp, and you see a small membranous area, which is fairly typical of pulmonary atresia, this membranous area that you can see here, which is got a little label on it that says, put the wire here. Of this one, obviously not the case. And there may be some argument made, although it seems to be becoming less important, that the surgeon can actually do a better job at opening this valve than the interventionalist. But I'm not here to discuss that issue. So when we use the views to look at this, we have to use a full complement of views, because not only do we have to evaluate the right ventricle, but we have to evaluate for additional problems like the pulmonary arteries, where how is the pulmonary blood flow supplied, and then complement that with Doppler techniques, Doppler color flow, look for additional signs of coronary fistulae, and how we can support the circulation. And so a full complement of studies is necessary for doing this picture. Now, just for those of you that have never attended here, and for those of you that have, the pictures will be as follows. Firstly, we will show you the fan overlaid across the specimen to show you how the echocardiographic plane was cut. And then you see the specimen, the echocardiogram on the right. The next thing that happens was the fan will disappear and the labels will indicate what we are seeing. And this is a severe case of pulmonary atresia. You can see the papillary muscles, which tell you that there's a valve present, because when there's no valve, there's no papillary muscles. So there's a small valve here. The ventricle is extremely hypertrophied, okay? Compare it to the left-sided left atrium and left ventricle. You see the hypertrophy that is developed on the right atrium in its attempt to push blood through this structure. And we don't show a foramen ovale, but that's almost invariably present in these conditions. And here you can see in the echocardiogram, the labels showing you the atrial septum, right atrium, left atrium. It's an apical four-chamber cut. Here's the descending aorta, left atrium and left ventricle. And here's this little tricuspid valve. And here is this hypertrophied right ventricular myocardium. And the labels will go on, and then the image will move so that you can just look at this in real time. And then the labels will disappear. And as many of you are looking at this on a smartphone, And my app has been designed for the smartphone. It zooms up so that it fills your screen, so you don't have to squint your eyes to see everything. And it presents it very clearly that the comparison of the size of the right ventricle is there. There are variabilities between the echo and the autopsy specimen. And there you see the valve leaflets opening. The leaflets are thickened and rolled. The atrial septum is domed, and the ventricle has got very little in the way of any contractility about it. Now, that was an apical 4-chamber cut. And as I said, we're going to go through the cuts. Here is a subcostal coronal cut. And here is the specimen. The fan is off. And you can see the right coronary artery has been amputated in this cut. Here is the coronary fistula is present. So this is in a way, a tripartite right ventricle. Here's the pulmonary trunk and the atretic muscular obstruction that occurs underneath the valve. And then the echo will show you a comparison of the valve. There's the superior caval vein, the aorta, pulmonary trunk here with a nice sized ventricle, a small infundibular area, sinuses with papillary muscles and an inlet, and marked right ventricular hypertrophy. And of course, excuse me, by tilting up a little bit, we get to see the great vessels, and you can see the origin of the left and right pulmonary arteries. And here is the arterial duct coming into the pulmonary artery over here. And we'll zoom in on that so that you can see that all very nicely. And you see the bifurcation of the pulmonary arteries into the hilum of the lung on both sides, with what appears to be a little stenotic origin at the pulmonary artery. So certainly, this is a very important way for looking at these structures. Now we'll look at the subcostal coronal cut one more time. And in this heart, there is an infundibulum present down to a atresia of the valve itself rather than the infundibulum. And here is the echocardiogram showing you the same features. And you can see the tricuspid valve, the tendinous cords, the infundibulum, the pulmonary valve, and the pulmonary trunk. And I'll place that in motion. And then also in the subcostal coronal cut, what I found very useful is to do a little bubblegram with aerated saline. And here is the flow coming into the right atrium, crossing the atrial septum, going into the morphologically left ventricle, and then coming across from the tricuspid valve and entering the right ventricle. But you can see that the flow coming into this right ventricle is really much smaller than the rest of the heart. So here you can see a highlighting of the cavity of the right ventricle. Now we turn the probe around at 90 degrees into the sagittal cut here. Although we're looking at the echo the same way as we did before, and you've seen the specimen with the right ventricular outflow tract down to an atretic pulmonary valve, left atrial appendage, aorta, right atrial appendage, the right ventricular muscle, the papillary muscle, and so on, and the coronary arteries on the surface. And now we cut at 90 degrees to this, and we see the right ventricular outflow tract and the aorta, and you see how the development of this progresses during the course of delivery, because these are all post-mortem specimens now. And you can see how this, just a little bit more hypertrophy is going to keep the infundibulum closed, and then it becomes permanently closed with muscle obscuring the entire outlet. Here's the pulmonary valve still moving and the pulmonary arteries above it. Still pulmonary atresia. Now we'll look at the valvar atresias, and here is another example of valvar atresia in the sagittal cut. What you can see in this specimen is the beautiful band of what is called the parietal and septal bands of the crista, which we call the ventricular infundibular fold. You can see the rolled, thickened edges of the 3 leaflets of the tricuspid valve and the abnormal thickened chordae tendinii, which are present here. Here is the pulmonary valve that we see before from the from the view from above. And here is on the sagittal plane the example of a tripartite ventricle, which is filling. Here's the septomarginal trabeculation, this muscle here, which you see very beautifully in the heart and is sort of overlooked many times echocardiographically. The thickened right ventricle and the domed but non-opening pulmonary valve, and a nice large main pulmonary trunk with the left pulmonary artery origin and also the origin of the arterial duct seen above here. And we'll close that out and zoom in the specimen. Oops, didn't zoom in. I don't know why. Sometimes the computer doesn't obey. Okay, no movement. So here we look at the pulmonary valve in parasternal short axis, and you can see the aorta and pulmonary artery, but here we're concentrating on the pulmonary valve, and you see the sinuses of Valsalva, but no opening in the valve. They're the sinuses indicated by arrows. And here, when we look at motion on the valve, you can see nice right coronary and left coronary coming off the aorta with a normal tri-leafleted aortic valve with the valve leaflets opening. And here, as the Mercedes-Benz sign stamped perfectly, indicating that there is no actual opening of the valve. And if you turn this round just a little bit, you get a long axis of the pulmonary artery. And you can see the doming, a non-opening of this valve, together with the flow coming from the arterial duct and coming down towards the valve. No flow, no insufficiency, and no outlet from the right ventricular outflow tract. So I think really nice example of a atretic pulmonary valve with a wide open infundibulum, but no opening across the valve. Now we look, at the short axis, and that provides some very useful information about the thickness of the ventricle and the thickness of the ventricular septum, as well as the size of the cavities and where they go to. And so here you see a parasternal long axis cut showing the outflow tract from the pulmonary artery ending blindly, and the aorta coming from this little left ventricle. And you notice the difference between the thickness of the right ventricle, the ventricular septum, and the left ventricle. So the right ventricle is obviously thicker than the left ventricle, but the septum is huge because the septum is made up of 2 parts. It's made up of the muscular ventricular septum and the overlying supraventricular septomarginal trabecular septum marginalis, or trabecular septum here. So this is the parietal band, the septal band of the crista, as other people would call it, but which we call the septum marginalis. Okay, well, we've shown that before. So that's why the septum is so much thicker. This is not hypertrophic myopathy. This is pulmonary atresia. Now we look at the arterial duct, and the arterial duct, of course, is the lifeline in this patient. It's particularly important to look at it after birth because it can mean the difference of life and death. So I think it's very important, and this is certainly one of the conditions where the use of prostaglandins has saved many of these children from a terrible fate. So here you can see the right ventricle has been opened. It ends blindly. There's a small pulmonary artery, suggesting this has been long-standing. And then here is the aorta with the arterial duct arising off this structure right over here like this. The left pulmonary artery is not seen. So this winding serpentine nature of the ductus is a feature of this condition. And because blood flow in the fetus is coming prograde into the aorta and the duct and then into the pulmonary arteries, rather than from the right ventricle into the descending aorta, the orientation of the arterial duct is different, and it is a much more vertical and serpentine in its description. And here you can see, here is top and bottom, front and back. This is not quite suprasternal, it's a ductus cut, which is a high parasternal cut. And you can see here the vessels of the head and neck off the aorta, the descending aorta. And here you can see the arterial duct winding its way into the pulmonary artery as you see it here. And you can support this with Doppler color flow as well. So the ductus is often vertical in this condition and tells you how the fetal physiology was occurring. So there you go. Now, not all shunts are this way. Here is a central aortopulmonary shunt. And you can see that by scanning up and down on the ventricles and seeing in short axis the cavities of the ventricles. This is a very small right ventricle. Here's a normal sized left ventricle. Here's this septomarginal trabeculation running on the surface. Here's the actual true ventricular septum. So there's a tremendous RVH, right ventricular hypertrophy. And here is, you see the same view, but from the subcostal sagittal cut down below. And here's the liver, and here's the left ventricle with its two papillary muscles. And here's the right ventricle. And these are the same, from the same patient. So you can see merely by sliding the probe down in this direction, you can keep the plane absolutely established and see virtually the same things in these two planes. So now let's go and look at the right ventricle, which is obviously the most important thing. And here is the diminutive right ventricle that we've seen before. And here are the echocardiograms showing you the difference in the fetus between the right and the left ventricles. And the fate of this heart has been pretty much established in the fetal exam. And here's a postnatal exam on the right side in the 4-chamber cut, showing the right and left ventricles, the right and left atria. And there's added delight here from the Doppler color flow, which doesn't show the actually atrial left to right shunt. And there's a tiny amount of pulmonary, of tricuspid regurgitation, and maybe a few coronary fistulae are also seen with the Doppler color flow. Let's just superimpose that here. Have one look at that one more time. So here, there's almost the same comparison of size, proportionality that remains from the time of in utero life. So many of these are set in utero, and there's nothing that can be done to increase the size. Now here is the second example, which we showed you with the infundibulum and the tricuspid valve obstructing the entrance into the right ventricle of the pulmonary blood flow. And there you can see a comparison here with the little tricuspid valve. You can see these ventricular coronary fistulae, which used to be called sinusoids. So if you don't know what I'm talking about when I talk about ventricular coronary fistulae, I'm talking about what you used to call sinusoids. And they probably are a more appropriate term, ventricular coronary fistulae. And they represent primitive intraventricular structures entering into the ventricle. And of course, because there's no egress and because the pressure is so high, the flow in these structures is retrograde into the coronary arteries and become a very, very important issue in terms of deciding about management of these patients after birth. Okay, we'll see many more ventricular coronary fistulae. Now here's the larger ventricle, what you'd hope for. There are two planes here. There's an apical and there's a subcostal coronal cut. So there's the apical and here's the subcostal coronal cut here. And you can see the infundibulum is widely patent, but the valve is atretic. Nice developed right ventricle, big hypertrophied right atrium, probably with tricuspid regurgitation. I don't know whether these match up the tricuspid regurgitation, but I've chosen just to show the black and white image here of what looks like a fairly large, in fact, enlarged right ventricle, still with pulmonary atresia. And you see the atrial septum, the two parts of the atrial septum flapping into the left atrium. Probably one of these is the primary atrial septum or septum primum, as we call it. And here again, looking just at the ventricle, you see the tricuspid valve, you see the enlarged right ventricle, and you see the atretic non-opening pulmonary artery within the pulmonary trunk. Now here we see the small main pulmonary artery and the arterial duct. Here comes the arterial duct retrograde. Here's the right pulmonary artery. The left pulmonary artery is going into the screen. You can't see it. Here's the atretic valve with the prominent septomarginal trabeculation and the ventricular infundibular fold, which the Van Praaghians would call the parietal and septal band of the crista and the thickened valve leaflet. But here we concentrate on this area up here, which is the small pulmonary artery and the arterial duct. And that's very important. And here we can see what we see in pulmonary atresia with intact septum, as opposed to pulmonary atresia with a ventricular septal defect, the so-called tetralogy with pulmonary atresia, is that the pulmonary arteries are much better developed, although they are small because their flow is limited by the demand. And there's the arterial duct in the middle. I'm going to take the labels off for you. Right atrium, right ventricle. And now you can see the central shunt coming in above the ductus. The reason you can't see the ductus is the ductus enters the pulmonary trunk from above. The vessels come out on the side. Here the ductus enters from above, and here the vessels come out from the side. So a very nice look at the pulmonary arteries to the hilum of the lung on each side. And then, of course, because of the oxygen after birth, you in the air sacs, you can't see the pulmonary arteries in the lung, as opposed to the fetus. Now, here we're going to look at the presence of tricuspid regurgitation. That's a very important issue, and we can see many things of importance here. First of all, we see this is an apical four-chamber cut we're going to look at. You can see how beat up and abnormal this tricuspid valve is. You don't normally see tendinous cords that look like this coming up on the septal leaflet of the tricuspid valve, or these thick cords going down to the anterior papillary muscle. Here's the blind end of the pulmonary trunk, and here's the anterior interventricular artery. So the left ventricle is just seen on the other side of this heart, opened in clamshell fashion. And here is the echocardiogram that we have shown for you here. And the echocardiogram shows a huge jet of tricuspid regurgitation, presumably because the pressure is about 53, 3.5 meters per second here. And so you see the jet begins proximal to the valve leaflets with this beautiful pisa here. I can try and stop that for a moment. and show you the proximal isovelocity surface acceleration. So here's blue flow going in the right direction, and here's the boundary of the first alias, and here is the vena contractor showing you the narrowest part of the jet, and then the jet domes up and billows both ways as it hits the posterior aspect of the ventricle. You see it going in both directions like a mushroom-shaped cloud. And also when we look at the Doppler, we can see that this ventricle is a sick ventricle. Number one, systole is very long. Number two, diastole is very short. And number three, the rate of acceleration, or the dPdt of this signal, is very slow, suggesting the ventricle is squeezing with a functional disability in terms of ejecting blood out of the right ventricle, because the only way it's ejecting blood is retrograde into, well, I won't say only, but the most prominent way is retrograde together with presence of fistulae. So we'll get to see that in a moment, but we're not concentrating on that now. So having mentioned that, here's a dysplastic valve, and you can see this tiny little tricuspid valve in a small right ventricle with massive right ventricular hypertrophy and an alternate source of egress from the ventricle. And here runs a sinusoid or coronary ventricular coronary fistula all the way to the surface to enter the coronary arteries. And we'll pay some attention to that in the upcoming slides. So there is this little junior, very small tricuspid valve present in it. And of course, if we look at this from the atrial aspect, here's the oval foramen, and there's only the right atrium open here in this heart. Here's the right ventricle shrouding it. And here you can see an orifice of the tricuspid valve with 3 leaflets in it that's smaller than the oval fossa. Okay, and of course, that's what it looks like. We can't see it in this plane, but in the apical 4-chamber plane, you can see this diminutive tricuspid valve, a very small tricuspid valve. And here is an open ventricle. We've seen the specimen before. Here's the infundibulum to the atretic pulmonary valve, the outlet, inlet, and trabecular component of the ventricle may be suitable for a 2-ventricle repair. And here you can see this little infundibulum. We've seen this picture before, but I wanted to show you once again the fused pulmonary valve leaflets and this critical area of development here, where there is tremendous massive hypertrophy of the parietal band of the crista here, or the ventricular infundibular fold, and the septoparietal trabeculations, which also enshroud the right ventricle and cause it to become diminutive, the right ventricular outflow tract. And here again is a picture in the sagittal cut. So this is front, back, top and bottom, not left and right, front, back. And here you see the diminutive ventricle here with the outlet down towards a fused tricuspid valve. And here's the pulmonary trunk. And here's this right ventricle, which we've slowed this down. This patient did not have heart block. And now we look at the pulmonary valve morphology, which we've seen before, but now we'll look at it with echocardiograms. And here you see the 3 sinuses of Valsalva with a tiny little triangular remaining in here. Here's the aortic valve, which is opening, big right coronary artery here. And here you see the tri-leaflet or Mercedes-Benz sign of this pulmonary valve leaflet without any opening. And a little bit of a clockwise turn brings you the pulmonary arteries with the coronary arteries. And here we see the base of the valve with the pulmonary trunk coming around here. So that could also be construed as a short axis. And they may vary because depending upon how much right ventricular enlargement is, the heart may be pushed into the thorax a little bit deeper, and it may be harder to see the pulmonary valve. So this requires a high suprasternal cut and short axis to look for that. Now we'll focus on the trabeculated right ventricle, and here you can see the trabecular associated with fistulae, not all fistulae, but you can see this tremendous hypertrophy of the muscular trabeculations within the outlet, with the inlet part of the right ventricle. Okay, again, a 4-chamber view with the standard labels on, and an effusion which is highlighted by the Doppler color flow because of the particulate proteinaceous matter within the effusion. It's not just water, it's got cells and matter in it, so it has Doppler characteristic, and it shows sometimes to and fro flow within the ventricle. Here we can see a heart of an 18 or 19-week fetus with pulmonary atresia, that the parents elected termination of pregnancy. And the problem was on this patient, right ventricular dependent coronary flow. And right ventricular dependent coronary flow, the treatment is usually cardiac transplantation, because once you lower the pressure by opening the valve, there's no perfusion of the coronary arteries, and the patient dies from a myocardial infarction. And here is a fetal echocardiogram showing you the right ventricle and the left ventricle for comparison. So, and there's a little tricuspid valve. And then we looked at this with color flow, and we could see on the surface of the heart a coronary artery, and we Dopplered this coronary artery and got this very bizarre flow signal. So this is the pathology of this particular echo. And here you can see that the left anterior descending coronary artery is entirely absent, and there's a big white blob, which usually occurs in these right ventricular dependent sinusoids or coronary fistulas. So you see a big white blob, and we'll show you the histology of that in a moment, which is characteristic, and there's no proximal coronary. So this is a right ventricular dependent coronary circulation. Here's another picture of the same. I've taken a different view to show the pulmonary trunk, the aorta underneath the right atrial appendage, no proximal coronary artery. There's the white bulb, and here's the rest of the coronary supply coming from the right ventricle. And here's an angiogram showing what you would find if this patient had lived to term. And here you see the right ventricle is filled, and then you see the left and the right coronary artery, and you see all of these fistulous communications. I'll take that off for you so that you can see it better. Okay, and then here is a matched echocardiogram from a patient after birth with coronary sinusoids. And this easy to see. Just remember that the Nyquist limit, or the scale, needs to be lowered in order to see these vessels. So the way I do it is I lower the Nyquist limit until the ventricle is filled with noise, and then I just increase the Nyquist limit just a little bit so that I can see these vessels. And I'm going to stop this so that we can look at it now in a freeze frame. And here you can see there's the whole ventricle. Okay, there's the tricuspid regurgitation. And then what happens is that in diastole, you see the blood filling out of the ventricle and into the coronary arteries. All right, so I'll let that play again for you. And I'll zoom in on it so that you can see that very beautifully, the picture of the fistulae. And not only are there fistulae in that direction, but you can also see fistulae developing in this direction towards the myocardium and the other coronary artery. So you see here that the diaphragmatic surface fistulae go to the right coronary, and the anterior surface fistulae go towards the left coronary artery. Here's the same heart turned on its side. I have many pictures of this 19-week fetus. And here you can see the aorta again, and no coronary, and there's the bulb. And here is a lateral or right ventricular angiogram. Here's the catheter coming in. Here's this inlet, trabecular, and outlet component. And here you see fistulae developing off the ventricle in different directions here. And here is the echocardiogram taken in the sagittal cut here, which shows you the same features. And you see almost a halo of signals coming across this right ventricle. So there's left ventricle, right ventricle, front and back, top and bottom, and you see the right right coronary artery coming over the front and the left coronary artery going around the back. Okay, now what do these fistulae look like? Okay, here's a beautiful example, again with the proximal bulb. Here's this anterior descending coronary artery going in towards the left coronary. The right coronary is running down here and we can't see it. Here's this incomplete right ventricle, pulmonary trunk, aorta, right atrium, and left ventricle. And this is a myocardial cut through this area. And you can see here is the endocardium. So this is the full thickness of the right ventricular myocardium. It's several millimeters thick. You can see the muscular bundles within the right ventricle. And here on the surface is this abnormal coronary artery. So these coronary arteries, when they are fistulae present, may not be normal. And here you can see, here in this area, you can see the hypertrophy of the muscle, almost Kawasaki-like, leading to very small areas of coronary artery flow. So there's a lot of hypertrophy and obstruction, and perhaps that's why when we saw the fetal echocardiogram, there was not a normal signal as you would expect to find here when there were just regular coronary arteries, as in this particular patient, but that the coronary flow is somewhat restricted. So flow is not restricted. The prograde flow in systole is out of the coronary artery, and as we saw in the echo, it's only into the myocardium and the coronary arteries in diastole. And even this signal doesn't have a normal amount of flow in diastole into the coronary arteries. But this particular example that we showed here in the sagittal cut shows, in fact, a very nice diastolic flow coming into the coronary artery. So only in diastole is there prograde flow. And in systole, there was no flow. And here is the systolic and diastolic signal. You need to get the Nyquist limit to lower than 69 here to see the prograde flow, which is coming at a much lower velocity. Here's another heart that was sent to me from an outside pathologist who decided to put an elastic band around this with a label. And of course, that scarred the ventricle. So here you can see 1, 2, 3 of these fistulae over the heart here. I'll take the labels off so that you can appreciate that. This specimen was just too beautiful to not put in this example, because you can see the coronary fistulae all over the place with ventricular dependence. And here's an example of a coronary fistula that you can see from the coronary artery entering this way retrograde and filling into the aorta. So this is an example of a coronary fistula, but not a dependent coronary fistula. Okay, so there's the ventricle. There's the entrance into the coronary. Here's the left anterior descending, running retrograde into the aorta. See it much better with color flow than without. Okay, so now we've got to look at what happens after birth. Here's a Blalock-Taussig shunt for a patient. Here's the superior caval vein. Here's the trachea, brachiocephalic artery, and the aorta. I'll take the label off there so you can see that clearly. And here's the shunt. You can see a little green line in the that recognizes a shunt. And the shunt is actually going not into the central pulmonary artery, but to the origin of the right pulmonary artery before the epiarterial supply goes up here. And so here you see the right pulmonary artery to the central confluence here, where the bulb of the pulmonary artery is. And here coming into the middle part of this right coronary artery is a Blalock-Taussig shunt, Blalock-Taussig-Thomas shunt. Excuse me. So a beautiful example of that. And here is the other kind of shunt. There's aortopulmonary shunt, and the specimen has probably been not rotated round enough, but this is more superior and this is more inferior. So when you see the BT shunt, you see the origin from the aorta here, and then the entrance into the pulmonary artery as the sweep goes down inferiorly. Let me take the labels off so that you can see that. And once again here, the use of Doppler color flow, appropriate Doppler color flow at a normal Nyquist limit, allows you to look at the shunt from its origin through its course and into the branch pulmonary artery down below. Let's just take the labels off now. And we'll enlarge this for those of you that are having to look at this on an iPhone. Okay, proximal, distal, proximal, course, distal entry. Okay. Now, the last part of this discussion is going to relate to how you decide what treatment to give here. And the standard way of treatment is to measure the tricuspid Z-score as a reflection of the size of the ventricle. And while it is true, it's a pretty poor measure of the size of the ventricle. And yet, Dr. Hanley, with his group that did this in the Journal of Thoracic and Cardiovascular Surgery, said that if you have less than a 2.5 Z-score, and these are how the Z-scores go. So we have body surface area, we've got tricuspid diameter Z-score here, and then here is the size of the valve, okay? And so you can make a statement here if you have the size of the valve being a certain number of Z-scores under 2.5, that you can now go and repair the ventricle with a biventricular repair. The people from Utah, Luann Minnick and her colleagues, looked at the ratio between the mitral and the tricuspid valve. And if the tricuspid valve was under 0.5 in terms of a ratio, so this is half the mitral valve, then you would not get a 2-ventricle repair. This is a fairly easy signal. If you have to get the paper, you can go through this and work out what the Z-score is. Let me point out to you a very important thing about the Z-score is if you measure the tricuspid valve incorrectly and you make a small error, you can make a huge error in the Z-scores. Okay, and that's what these red and green signals involve here, because here you can see if you just make a little error in the size of the valve, you can have a huge difference in your Z-scores. And so I think the Z-scores are very useful, and most surgeons will accept this. But to me, it's much easier to actually look at the size of the ventricle. And how do we look at the size of the ventricle? We look at the size of the ventricle by looking at the cavity of the ventricle. And I've drawn this over here in the subcostal coronal view. Here's the tricuspid valve. Obviously, it's going to have a small Z-score. Okay, maybe if I've just taken the error a little bit down, I would have a bigger Z-score. But anyway, here is the outline of the ventricular cavity. And I've superimposed this on ventricles, and you must do biplane because of the shape of the right ventricle. So you have a coronal view, and you just turn the probe 90 degrees until you get the orthogonal view, and you get this particular measurement over here. Okay? And so we pretend that we use the left ventricle. This is the machine only does left ventricular volumes. So this is the mitral valve area, and this is the cardiac apex, and this is the mitral valve area, and this is the cardiac apex. And these are the short and long axis views of this ventricle. This is subcostal sagittal and subcostal coronal view. Okay. And so I've drawn those, and those are end diastolic frames. So you can see the ventricle doesn't have a whole lot of function in it. I'll take the labels off there. And we'll do the same here. There's the right ventricle. And so here you have the Z-score. Here you see the VZ here. You're not seeing it over here, but we're coming through the major part of the ventricle. And we would outline this, and we would come up with a biplane volume. And the biplane volume of this would be about 4 mils. Okay. Now, Dr. Hoffman, my colleague, looked at this to calculate the ventricular output on a variety of ways. And he said that basically, in order to survive, you have to pump more than 20 mils per meter squared. And he did it for different heart rates and different cardiac outputs. So here's the heart rate here. And if you take the heart rate at 150 here in this particular example, and you look at what the ejection fraction of the ventricle is, optimally, this is the ejection fraction, and that will mean you need this kind of a volume to get cardiac output for a two-ventricle repair on the left side, okay? And so if your ejection fraction is only 40%, then you would need about an end diastolic volume of about 28 milliliters per beat to get this out. Now, if you take 150 beats per minute at 20 per minute, you have a 1.5 liter per minute per meter squared cardiac output. And so he's done this for working on a cardiac output of 1750, 2000, or 2,500 mil per minute per meter squared, and developed these curves, which are only available over here and in this journal, the Cardiovascular Journal of Southern Africa, which is a defunct journal and probably not available in your libraries. So this is here the only chance you'll have to look at this scale. But when you look at the size of the ventricles and you see a ventricle that's got, let's say, a heart rate of 100 and it's got a volume of 5 mils, that's 100 times 5 is about a half a liter per minute, which is inadequate for cardiac supply. Usually it's 2 or 3 milliliters. If you say 2 milliliters is the volume of the ventricle, and you multiply that by 100, you only get you get an inadequate cardiac output. You need something like 20 milliliters per meter squared and an ejection fraction of 50% to get to survival areas. So by measuring the volume of the ventricle, you can also see whether you need to go down a one ventricle or two ventricle route. I realize it's difficult for a number of people, but I feel that it's important for me to mention that it's possible. And lastly, when talking about Epstein's malformation, you may get acquired pulmonary valve atresia. And this was originally seen as a fetus with Epstein's malformation. Here's the septal leaflet plastered against the ventricular wall, the big anterior superior leaflet, and also the plastered mural leaflet or inferior leaflet. And here is a probe placed in the pulmonary artery, and you can see there's no leaflets here. They just formed a fibrous plate across the valve. And of course, this is a developmental problem that occurs in Epstein's malformation because of the massive tricuspid insufficiency, and then the systemic pressure holds the valve closed and it develops pulmonary atresia. So in the course of looking at pulmonary atresia, we have to always consider whether we're dealing with Epstein's malformation. And here you can see the ductus is the only supply that gives blood into the lungs, and that there is no flow across this pulmonary valve, even though there's a reasonable sized ventricle on the other side. So that basically takes care of what I have to say to you. I hope you've enjoyed this, and I hope it wasn't too complicated for you. So I've got, on the questions and answers, I've got a long question. It's from Erna Ramsey Semmelweis. Thank you. Okay. Well, I agree with this. The question is a very, very complicated question, and I don't know that it's going to help anybody else to answer it, but basically I agree. Okay. So the question, and then another question anomalously submitted is, can we confidently distinguish from sinusoids with and without right ventricular dependent coronaries? And the answer is maybe, but with the current experience in the world on this condition, this must trigger a coronary and a right ventricular angiogram. And I think that's the important issue. And size doesn't help you. Size doesn't help you because you can have coronary dependent circulation with a big ventricle, as I showed you, or with a small ventricle. So the answer to the anonymous attendee there is that you must go and do a right ventricular angiogram in order to decide this. And of course, you know, most of the time now, the patients are going to the cath lab with this condition because they're going there with an intention to treat. So then, of course, the finding of the coronaries becomes a problem. And of course, if you've got these right ventricular dependent coronaries and they are a major problem on angiography, the only alternative for reasonable treatment is heart transplantation. Now, the next question is, when do I consider the right ventricular overhaul? Now, the right ventricular overhaul was actually an operation that was suggested by Roger Mee, the great Roger Mee from New Zealand and Australia and the Cleveland Clinic. And Roger said his main operation is on these patients first to do a shunt, and then at 6 weeks go back and then look and see whether he could cut out the muscle in the endocardial fibroelastosis and open the right ventricular outflow tract. That's one form of treatment. I think it's a good form of treatment. Dr. Mee had a lot of success with that procedure. We have gone for more primary treatment. And I think now when you put this in the hands of the interventionalist, the chances are that you're going to come back with a perforated valve if it's at all possible. And if it's not, the right ventricular overhaul was not the most valuable procedure. Okay. Okay, the next question requires, how do you distinguish tricuspid atresia from pulmonary atresia? Well, I think most of the time it's very easy. What I've always looked at in my own personal experience, and I sort of tried to bring out in the talk, was if you see tendinous cords, then you have a tricuspid valve, however small it is. I mean, I think that most of the time in tricuspid atresia, you can see that the right atrium is not continuous with the ventricle. And I think these are the two important connected to the ventricle. It's actually separate, and there's a separate groove, and there's fat present in the series. I did show that a little earlier. And if you look at my chapters, and if you go back and look at functionally single ventricles on the archived YouTube footing, you will see the difference between the tricuspid atresia and the pulmonary atresia. The one that there really is a problem, and I have almost no experience with this at all, is tricuspid atresia type 1A, where there's tricuspid atresia and pulmonary atresia. And I have no experience with this condition, but I think that they are really very easy. And the other thing about the pointer is once you've got tricuspid regurgitation and you have papillary muscles, then you have definitely got a tricuspid valve. So I think that I'll leave that at that question. Let's see, there's another, everybody's anonymous this morning. Yes, the answer is if you have a coronary dependent circulation, do we go down the single ventricle pathway? Yes, yes, except that you may, by doing all of the things that you do, lower the perfusion pressure, and then you get escape of blood from the coronaries back into the veins, and you can get ischemia. So I think that the treatment is, if you've got dependent coronary circulation, the answer is really a car transplant. And the patient that I showed you with the big coronary artery a little earlier on this morning had came from the Cameroon in Africa, and there's no heart transplant facility for her. And so we attempted to do a BT shunt to put her down a single ventricle pathway, and the patient died within hours from coronary ischemia. So that's certainly something that you have to be very careful about. Let me go off this here, and let me just go and see what the chat icon shows. There's lots of things on the chat. It's unfortunate. Everybody's calling from around the world. Thank you. Yeah, the QR, well, I don't know what the codes are, but if you go Congenital Heart Academy, that Grace had showed you at the beginning, and you use that, you can get a whole series. If you go previous videos, you will see a whole series of these videos, and you'll be able to do that. And somebody has thanked Dr. Adrian over here, but Adrian hasn't been here today. I wish he was, but he didn't say anything. Okay, we've got people from Argentina and from Da Nang. So I think that we've answered as many of these questions, and
yes, Norman,
I look forward to seeing you
we
soon.
have Adrian. Hi, Adrian.
Oh, Adrian is here?
Hi. Hi, yes. Can you hear me?
Yes.
Oh, Adrian, I'm sorry, I didn't see you. Let me just escape from this, and let's have you make a comment. So I'll stop sharing my screen. I'm trying to stop sharing the screen. Yes.
Yes, yes, it's done. It's done.
Okay, here we go. So is Adrian here? I don't see him.
Not in face, but probably. Adrian, are you okay with the connection?
Yeah. Let me just show you this patient once again that we had to.
Norman, I was able to interesting lecture. Thank you.
Oh, there you go. Hello, Adrian. Yes. Thank you for coming.
Yes, I'm. It's been a wonderful lecture. I really enjoyed it.
Thank you very much, Adrian. So I don't know whether you guys can see my screen, but for those of you that are still present, I'm going to share the screen for you one more time, and I'll show you this patient from the Cameroon on the right here, and you see this massive coronary fistula here. Now, the perfusion of the coronary artery is held by the diastolic pressure in the pulmonary artery, and by lowering it, by doing a shunt, there was less perfusion of the coronary here, and the patient died within hours of the procedure. It was all we could offer her, and she didn't want a transplant, and she couldn't stay in America. So this was the problem that we were encountered here. And I can tell you that the only treatment for the ventricular dependent coronaries, as I see it, and Adrian, perhaps you can put in chime here, is to do a transplant.
Yes, and absolutely not to decompress that right ventricle.
That's right.
And also people have to remember that when such fistula or communication are present, they are made or even more dangerous by the presence of stenosis or even of atresia of the aortic orifice of the coronary arteries. So the coronary arteries can be stenotic or even atretic in these patients. That creates the actual dependency onto the right ventricle for the coronary circulation.
Yes, sir. I think I showed that in the pictures that I've got a histology of the cross section of the outlet that looks almost like it's got Kawasaki disease. There's a hypertrophy, endothelial proliferation, and obliteration of the cavities. So that's an ongoing problem with this, and that may be independent of whether you do anything to these patients. I mean, even if you do just a single ventricle without decompression, this might get worse.
Yeah, and I wanted to ask you a bit more about the role of tricuspid regurgitation, because I think depending on its level, and it can be quite a good factor to develop that right ventricular cavity to avoid the creation of the fistulae, and actually to allow us, to come back and maybe gain a 1.5 ventricle repair in these patients.
Well, I mean, I think that tricuspid regurg, I never thought of it as a form of treatment. I mean, I don't think that as a fetus, nobody is ever going to go in and do a balloon valvuloplasty on a tricuspid valve. So the real issue that we faced with in the world of today is that if you have a lot of tricuspid regurgitation, the ventricle usually develops. Okay, because the blood is flowing back into the ventricle, and at least there's flow going to and fro across the tricuspid valve. And you may get even giant right ventricles. Okay, so yes, then of course, the other thing is when there's a lot of tricuspid regurgitation, there's less stimulus for the development of these fistulae. And so the bigger the ventricle, the less the fistulae. But I still remember the great Bob Freedom I wrote a paper on this many years ago, and his final remark about this pulmonary atresias was, how could something that's that small cause so much grief? And the grief is spread around. I mean, it's obviously for the families of the patients, but it's for us as people that treat these kids, because they are a tremendous challenge. And, I mean, it's like playing bridge or poker. If you dealt a bad hand, there's almost nothing you can do to win the hand. And I think the same is true in this condition. And the other point that Bob Freedom made, the late Bob Freedom, made a great contribution to our understanding of pulmonary atresia, was that he showed pictures of a big ventricle with the right ventricular dependent coronary fistula. And so he convinced me that was my original paper said that you don't have to catheterize patients with big ventricles, was that you have to catheterize them because basically you can't be caught surgically doing a procedure which is going to cause the patient to die. You need to have it. And so most surgeons will ask for a fistula, for a catheterization. And I would support Bob's contention that it's actually absolutely important, that you can't get away without doing a catheterization.
Indeed. Do you see much endocardial fibrolastosis in these patients, Norman?
I think I see some, but you never see the same thing that happens in the left ventricle. So I think you can see patchy fibrolastosis, and I'm only saying that, well, in my specimens, there are very few examples of fibrolastosis, but on echo, you see this very bright endocardium, particularly on the papillary muscles, So I do think it, but, that was, in fact, some of the thing about the Roger Mee overhaul procedure. He said that, you take care of it, you make the ventricle bigger, and you take out the muscle. And that's what he called the overhaul. And I think certainly when we look at EFE on the left side, where Dr. Reddy and Dr. Del Nido and Dr. Hanley have taken out the endocardial fibroelastosis on the left side, even if the ventricle doesn't contract much better, it does contract better because it fills better, but the volume of the ventricle is larger. And so the movement, even if it's not substantial, creates a greater ejection fraction. So I think that that would support the overall philosophy that Roger Mee supported. I don't know whether you ever do that procedure, Adrian.
We do overhaul when it's doable for the right ventricle, because the audience probably understood from your lecture that there is a difference between a ventricle that is tripartite in its walls and tripartite in its cavity. You may have a good sized ventricle, but with a very small cavity because it's so much overgrown inside.
Right. I think that showed it. Do you do, is your standard procedure, you do valvotomies? Your people are probably doing the angioplasties. I know them well.
Yeah. If possible, we go by radio frequency ablation if there is a state of a valve. But then we tend to use even the right ventricle to pulmonary artery shunt instead of the classic Blalock-Taussig Thomas shunt.
Yes, you do what kind of shunt?
Like the Sanotype, the right ventricle to
yes. Okay. Well, that's interesting. So, I mean, there's many ways of killing a cat, as they say.
Yeah, indeed.
Norman, can I ask you something?
Yes, Sasha.
We have few cases that when they were newborn was pulmonary atresia and that ventricular septum, but the fistula was not so clear. And they, after 1 week, after 2 weeks, the fistula became very, was very easy to see that. There is some, changing in, I don't know, pulmonary hypertension, vascular resistance, or other things.
Yeah,
Sorry.
It's developmental changes, and maybe, I think that they can change it, but I think that, the problem is that I think if you do an angiogram, an RV angiogram, you will see the fistulae. And I think that you have to do that. It's hard not to do that. And, go back and look at the angiograms. But I think that the standard policy and what we need to tell the Congenital Heart Academy people is that, you have to do good angiography. We're losing our audience, so people have had a lot. But from my point of view, the one question that I want to ask when I look at the pulmonary valves, I think the surgeons can do a much better job on the pulmonary valve than the interventionalists. And you know what I see sometimes, Diane Spicer showed us a beautiful example a couple of weeks ago, where somebody does the radio frequency ablation and they put it through the sinus of Valsalva and not through the cavity. So now you've got a lousy valve and you've got pulmonary insufficiency off a commissure. So what do you think about surgery on the valve versus balloon radio frequency ablation and balloon valvuloplasty?
For me?
Both are surgeons. I mean,
yes. Adrian.
So probably, Norman, you've just seen the paper published in JACC from Toronto regarding the left side.
Yes, I saw that.
So I read that on a journal club because it's an interesting paper. Yes. I have to say that even more for the right side, the interventional cardiologists now took precedence in opening this outflow tracts.
I think that's the case, even if it's inadequate. The other problem about these patients, both the left and the right side, that's on the table. The issue is that these are not wonderful patients, and they're not perfect substrate, and they have ongoing problems. And this is the other issue. And it seems to be that if you look at the survival curves, that even with the balloon valvuloplasty, these patients are doing well. And I think that was the point of the paper from Toronto, is that what they did that made the strong argument for them is that by doing the interventions, they found that the patients lived well, many of them without operations, and if they had operations, they didn't die from them. They carried on and had reasonable lives. So I think that that sort of solved the problem.
Sasha?
Yes, no, I fully agree with all of you. We have a case done 2 weeks ago by interventional cardiologists. I don't think there is no more space. It means it's very difficult to select a case for surgery rather than for interventional. So our first approach for sure is interventional. And sometimes we leave PDA open for 1 2 weeks, and then we see. We have this case, was very small child. It went very well, and we are very happy. So I really believe in this strategy.
So there's just one other question for Adrian here, because he said used like a Sano kind of procedure on the right side. Are you stenting the ductus now in your interventional procedures? Yes or no?
We do when it's feasible. As you discussed very nicely, the duct can be tortuous sometimes, can be long, it can be difficult. So we do discuss with our cardiologists, and if they are happy to stent it, that's a possibility.
Great. Well, I think it's been a wonderful session for me. I thank you very much. And it's so great to have you here, Adrian. I'm sorry I didn't see you because I have to put, the things off to see this thing, but you're most welcome, and I enjoy your company so much. Thank you. And Sasha, thank you very much.
Thank you.
Ciao.
Thanks from all over the world. Today we have people also from Ukraine, and this is a big privilege.
Great to have the people from Ukraine.
This is a real privilege for us.
We wish you peace.
Yes.
Okay.
Thank you very much. See you very soon.